So I'm Taylor, I'm one of the PGY3s. I'm going to be giving my CCM lecture on bilious emesis in the newborn. I just want to take a moment to thank Dr. Saleh, Dr. Khan, Dr. Drenis, Dr. Chow, and Dr. Ruckin, one of our pediatric radiologists, for their help with this presentation. So we're going to start with a case. We have a 2-week-old born at 40 weeks, 6 days via uncomplicated, normal spontaneous vaginal delivery. They're being bottle and breastfed, presenting for repeat episodes of emesis since 8 p.m. The family estimates about 10 episodes occurring immediately after eating. Their last bowel movement was earlier that day, normal quality, no mucus blood, denies any fevers, rashes, head trauma, dyspnea, or cyanosis. And their last wet diaper was prior to arrival. So on review of systems, we're positive for appetite change, positive for vomiting, no change in activity, no fever, no crying. On physical exam, vital signs was afebrile, heart rate of 159, respiratory rate of 42, saturating 99%, so overall normal vitals. General appearance, they were active, not in any distress, non-toxic. Anterior fontanelle was flat, mucous membranes though were dry. Cardiopulmonary exam were within normal limits. Abdominal exam, there's no distension. There was tenderness with mild grimace with palpation and no hernia appreciated. Their skin exam, they're warm. Their capillary refill was less than 2 seconds. So at this time, is this, what we're thinking is this kid sick or not sick? So this is what we're always trying to figure out in the ER. It may be more difficult in pediatrics as these patients can't give us a history. But what we're trying to figure out, is this just spit up or is something more going on? And so for these patients, it's really important to dive into the history, specifically the quantity of the vomiting, the color, is it bilious, is it formula, is it clear acid smelling, is the vomiting projectile, or is it slowly kind of coming out of the side of the child's mouth? How often is it happening? Is it happening with every single feed or less than half of the feeds? Is the newborn completely not fazed by it, or are they crying and having abnormal appearance after these feeds with vomiting? Also the timing of the vomiting. Is it immediately after? Is it 30 to 45 minutes after feeds? It's also important to find out how the baby is feeding. Are they doing breastfeeding, breast and bottle? How often are they feeding and how much? This can also give you a sense of if they're appropriately feeding or if they're overfeeding. And if there's been any changes to feeding recently. Have they switched from breast to formula? Have they switched formulas? Are they giving a soy-based formula? Have they newly introduced cow's milk to the child? And then also too, has the child been appropriately gaining weight or are they losing weight? These are all kind of important things to get from the history to help you determine whether this is a child you should be more concerned about or this is something maybe normal. So on our differential for vomiting, the first thing that we kind of think about are GI causes. And I guess you can see on the board the quote unquote complaint of vomiting, but is this just spit up? But spit up occurs because the infant is swallowing air during feeds and possibly because of overfeeding. It's not forceful. Child is usually happy during it. It's a small quantity and it consists of just formula. Other things on the differential for GI causes could possibly be GERD. GERD typically happens not immediately after feeding with burping. It usually happens 30 to 45 minutes later. Sometimes it's acid smelling, but overall the child is still happy and developing normally, even with GERD. The step up from that, GERD with esophagitis, still has the same kind of symptoms, but they then start to have poor weight gain, feeding refusal, or marked irritability. These children may require treatment, usually with famotidine. Something that we see very often in the emergency room, gastroenteritis. You'll typically see it's like acute onset, often associated with some diarrhea. They'll have positive sick contacts, possibly viral URI symptoms happening at the same time, and fever. Another thing to keep in mind and be aware of, because if you don't know about it, you'll miss it, is food protein-induced enteropathy, or FPIES. This is vomiting and diarrhea and lethargy within 2 hours of ingesting the offending proteins. Some of these patients will have signs of anaphylaxis as well as shock from massive dehydration, and it occurs approximately 1 to 4 weeks after introduction of cow's milk, soy, or solid foods. And lastly, on the differential, and should always be on the differential in the ER, the most concerning thing that we need to think about and rule out in this vulnerable population is intestinal obstruction. And so this will be things that you should consider in a more concerning history where parents are saying that it's projectile, it's bilious, there's multiple episodes, child's losing weight, they're having crying, activity change, lethargy. And on physical exam, you'll find things like a lethargic newborn, dehydrated, abdominal distension. You might even see visible bowel loops and absent or increased high-pitched bowel sounds. And then in your differential for intestinal obstructive causes, you can kind of divide those into non-bilious and bilious. The first thing that we kind of always think about with obstruction is pyloric stenosis. These are typically non-bilious, usually happens within 3 to 6 weeks of age, and it's usually this forceful projectile vomiting. And the classic teaching is that you may be able to palpate an olive in the abdomen. Hirschsprungs, we won't typically see this in the emergency room, maybe only in home births. It's usually diagnosed in the nursery, but can have abdominal distension. They didn't pass meconium in the first 48 hours. They can sometimes have bilious vomiting, but usually it's not. And they sometimes have signs of colitis. Another important thing to think about with intestinal obstructive causes is for older children that can put things inside their mouths, so typically 6 months to 36 months of age, is a foreign body. They can have choking, vomiting, feeding refusal, and even in more extreme cases, esophageal perforation. Another thing to make sure that you're taking note of on your physical exam is concern for incarcerated hernia. These children may be irritable, and you can palpate a firm inguinal mass. And lower on the differential, just based upon the age of this child, but is intussusception. These are typically, again, older, 6 to 36 months. They have intermittent colicky abdominal pain with vomiting, possibly maroon-colored stools or hematochezia. And you can see something known as the dance sign, which is retraction of the right iliac fossil on exam. And then for bilious causes of vomiting, these are harder to kind of differentiate without imaging. These include malrotation with volvulus, intestinal atresia, antral or duodenal webs. Typically, intestinal atresia will present earlier, hours or days from birth with bilious vomiting, where malrotation with volvulus can occur kind of at any age. And for antral or duodenal web, it kind of depends on the severity of the obstruction. So if it's more severe, it usually presents in neonates with bilious vomiting and gastric distension. But if it's less severe, it may present later in life. And the common presentation for this is actually foreign body retention in a toddler. So although we always think vomiting, typically we think of the GI system first, it's important to not forget about other systems that can cause vomiting. So importantly, the CNS system, they have hydrocephalus, intracranial hemorrhage, mass lesion. They can present with a bulging fontanelle and kind of emesis with abrupt changes in body position. Always should think about infection in this population. If it's sepsis, meningitis, do they have a UTI? Also metabolic disorders. We also see them less frequently due to newborn screens, but you should check for hepatomegaly, may indicate galactosemia, or any kind of unusual odors may indicate an amino acid or fatty acid disorder from the infant. And then any abnormalities to their genitals can consider congenital adrenal hyperplasia. And the last thing to consider is cardiac causes. Less commonly presents with vomiting, but can present more with weight loss or poor feeding that may mimic vomiting. And these children will have cyanosis or sweating or grunting during feeds. So for the progression of the case, the patient then had 6 episodes of emesis in the ER, 1 episode of projectile bilious vomiting in the ER. So at this time, the differential kind of included malrotation with volvulus, intestinal atresia, or antral or duodenal web. So what should be our approach to these patients in the emergency room? So any patient that is unstable, is lethargic, has abnormal vital signs, has a acute abdomen, peritoneal signs, has hematochezia, or is in shock, these kids should get finger stick, labs, resuscitation with fluid, and urgent pediatric surgery consult. It's going to depend on your institution and the pediatric surgeon. Sometimes based upon the exam, the surgeon may take this patient straight to the operating room. after stabilization versus getting urgent imaging and then going to the operating room. In the patient that is stable, but maybe has concerning kind of clinical history findings, these patients should still get finger stick, line, labs, fluids, and followed by imaging. Typically in the ER, we'll get X-ray and ultrasound for these patients. Typically X-ray first, it's more feasible, it could be done bedside, followed by ultrasound. And then if those kind of imagings don't reveal any pathology, typically these patients come in for observation and upper GI series is performed inpatient. So this is kind of a combined flow chart I kind of put together for ED management of these patients. So like we discussed, any ill-appearing infant less than 1 year with bilious vomiting or peritoneal signs, this should be an immediate consult to the pediatric surgeon, fluid resuscitation, considering placing an oronasogastric tube for decompression, empiric antibiotics for bowel flora, and possibly being taken urgently to the operating room. If the patient is stable but has concerning clinical findings, as in vomiting, which is bilious, acute abdominal pain, any signs of diffuse abdominal tenderness or distension, these kids should get a finger stick, labs, fluid resuscitation, but will proceed with an abdominal X-ray. If on that abdominal X-ray there's any abnormal findings of bowel obstruction, this will then be indication then to get, again, pediatric surgery on board, OG-NG tube, antibiotics, and fluid resuscitation if it wasn't already initiated. If, on the other hand, it's kind of a normal versus a non-specific X-ray, you should proceed with ultrasound. So on your ultrasound, if you find any abnormal findings, typically signs of pyloric stenosis or volvulus or malrotation, again, you're on the same kind of pathway of ped surgery, OG-NG tube, antibiotics, and fluid resuscitation. If, on the other hand, you have a normal ultrasound, these kids are going to come in for observation in an upper GI series. Just to note, most abdominal ultrasounds will just be utilized to determine pyloric stenosis. So pretty much it's if no pyloric stenosis, then patients will need an upper GI series. So labs were obtained for this child. The CBC was grossly normal. COVID, flu, RSV were negative. Comp electrolytes were within normal limits besides the K that was hemolyzed at 7.8. UA, nitrite negative, Luke esterase moderate, some WBCs and some bacteria, but also squamous cells. The child was given 20 cc's per kg bolus at that time, and abdominal X-ray was obtained. So this is the abdominal X-ray. It's showing a non-specific air distension of the stomach in the left upper quadrant. Distal bowel demonstrates some scattered regions of air distension. No evidence of pneumoperitoneum, no abnormal soft tissue calcifications, and the osseous structures were unremarkable. So overall, the impression being read was non-specific air distension of the stomach, no evidence of pneumoperitoneum on this single frontal supine view. In talking to Dr. Ruckin about this, she said that she would have read it as mild gaseous distension of the stomach with paucity of bowel gas beyond the stomach, which she said is entirely also non-specific. It could reflect fluid-filled loops or decompressed loops and is indeterminate. Just to note here too, a single view is very limited. If you're considering obstruction or perforation, you should get 2 views, either a cross table lateral or a left lateral decubitus. Without 2 views, you may miss signs of perforation or bowel obstruction. So as the X-ray was non-specific, proceeded with a abdominal ultrasound. So let's see if we can play this. So on the abdominal ultrasound, the liver was read as appearing normal. The gastric pylorus was visualized. Its maximal thickness of the single muscular wall and the transverse thickness was 1.5 millimeters. The transverse diameter was 3 millimeters, and the longitudinal length was 7 millimeters. And you can see on this video, contents actually passing through the pylorus. You can see that right here. And so the impression for this ultrasound was no sonographic evidence of pyloric stenosis. Also see here in a still kind of the opening of the pylorus and not the thickened muscular wall. So just to give you a sense of what you would see on an ultrasound with pyloric stenosis, on the transverse image, you're going to see a muscular wall that's greater than 3 millimeters. So you can see here that this is being measured as 4 millimeters, so thickened. You're also going to see on the longitudinal measurement, the measurement here, greater than 15 to 17 millimeters. So this is being measured as 18 millimeters, as well as you're not going to see fluid kind of passing through the pylorus. Here's another example of this in like higher definition. You can see here that the pyloric muscle with the yellow markings is thickened and greater than 3 millimeters. And the no contents are kind of flowing through the pylorus, as well as distension of the stomach with the pink arrow here. So this child then went to the floor for observation and definitive imaging. The differential still included malrotation, intestinal atresia, or antral duodenal web. GI was consulted. They recommended an upper GI series and surgery consult, as well as if the upper GI series was negative, they would consider endoscopy. So this is the upper GI series. You can see here, this is the SCOUT image, which shows the enteric tube in satisfactory position and the bowel gas pattern, which is normal on this SCOUT view. Then contrast was given, and enteric contrast fills the stomach and progressively opacifies the first and second and third part of the duodenum. But the fourth part of the duodenum, or the duodenal-jejunal junction, is not demonstrated in the left upper quadrant position. And then sequential images show contrast in a distended descending proximal transverse duodenum, but none of that contrast progresses across the midline into the left upper quadrant. Then after about 20 minutes, they take another image, and a small amount of the contrast is seen opacifying small bowel in the right upper and lower quadrant. And then about an hour afterwards, they can see partial opacification of bowel loops in the right lower quadrant and lower abdomen. And the presence of contrast within the distal relatively decompressed bowel loops with retained contrast in the distended stomach and descending duodenum on these delayed images confirms that there is delayed clearance from the stomach and the duodenum. And these findings are consistent with a partial obstruction, likely at the level of the transverse portion of the duodenum. So these findings are suggestive of malrotation with partial obstruction, likely due to Ladd's bands. There's no focal distended loops of small bowel or contrast pattern suggestive of volvulus. So after the confirmation of this diagnosis, surgery was consulted. They got a repeat potassium that was normal, and the patient was taken to the operating room. So let's talk a little bit about why this happens in our favorite topic of embryology. So at the 4th to 8th week of embryonic development, the quote-unquote abdomen cannot accommodate the rapidly expanding GI tract, and the bowel leaves through the future umbilicus. The bowel then rotates 90 degrees counterclockwise, and then at the 8th to 10th week, returns to the abdomen and additionally rotates 180 degrees counterclockwise. So overall, the bowel rotates 270 degrees counterclockwise, and then is fixated at the ligament of Treitz. So in abnormal development, rotational anomalies occur as a result of the arrest of normal rotation of the embryonic gut. So in type 1, known also as non-rotation, no rotation occurs at all. So the small bowel is found on the right and the colon on the left. This is the most common form actually of malrotation. It has a male predominance of 2 to 1. And this is not dangerous at all. It doesn't lead to volvulus or any sort of obstruction. Your type 2, which is incomplete rotation or malrotation, is where the duodenal jejunal limb remains in a position of non-rotation. So the small bowel does not rotate, and the cecocolic limb, the large bowel, has partial rotation, usually 90 degrees instead of 180, and that results in the cecum in the mid-upper abdomen. This is the most commonly formed surgical treated cause of malrotation, as this can lead to volvulus and obstruction. Type 3 is known as reverse rotation. That's when there is clockwise instead of counterclockwise rotation. And this results in the duodenum that rests on the SMA, or the transverse colon that is posterior to the SMA. And so the SMA actually causes obstruction of the colon. So how does malrotation with volvulus occur? Is when the small bowel actually twists around the SMA and it results in bowel ischemia. This results in vomiting, fluid loss, and sepsis. And 1/3 of children who have malrotation will present with volvulus. In the case of our patient, they had malrotation with Ladd's bands. This occurs because Ladd's bands cause duodenal obstruction. So patients with malrotation, mostly by the age of 1, 30% of them will present to the emergency room or to medical care. Before 1 year, about 58% of them will present, and before 5 years, about 75% of them will present. It's important to note that patients with intestinal malrotation, more than 50% of them have another associated anomaly. So most commonly congenital diaphragmatic hernia, congenital heart disease, or omphalocele. So it's just important to be aware that they can have other complications as well. It's important to note that patients with malrotation with Ladd's bands, that doesn't cause complete obstruction, or patients with malrotation that don't have volvulus, they may present kind of with vague symptoms, and their workup may lead to a diagnosis of malrotation without volvulus or without obstruction at that time. It's still important for there to be a discussion with the surgeon and the parents regarding surgical management for these patients, because 1/3 of them, 1/3 of newborns will present with volvulus, 22% of older children will develop volvulus, and 12% of adults will present with volvulus if not surgically repaired. So it's important to distinguish between a patient who has malrotation with no signs of obstruction, so therefore like no Ladd's bands or no volvulus causing obstruction, versus those that actually have, at the time of presentation, evidence of obstruction, being volvulus or Ladd's bands causing complete obstruction of the duodenum. So just want to talk about the other things that are possibly on the differential for a patient with intestinal obstruction. So this is intestinal atresia. It's a blockage of any area of the intestine, but it's usually the duodenum. So this picture here shows duodenal atresia. During early gestation, about 6 to 7 weeks, portions of the intestinal tract become occluded as the endodermal and epithelial proliferates. Patency is then restored as recanalization during weeks 8 to 10. So duodenal atresia is thought to result from the failure of the bowel to recanalize during this period. And classically, this is seen on abdominal X-ray as a double bubble sign that you can see here. So here's the first part, the second part of the bubble. And usually also too, distal gas will be absent. This strongly suggests duodenal atresia. In comparison to jejunal or ileal atresia, which is more rare, this is typically thought to occur due to an acquired lesion result of vascular disruption that leads to ischemic necrosis and a segment of the fetal intestine not developing. There are multiple different types. So you can see here that type 1 is a web-like membrane that forms inside, versus type 2, which is a blind end with a cord of fibrous tissue that connects the two. Type 3, which is the most common type. There's type 3A, where there's a blind end and it doesn't grow to normal length or connect. And then type 3B, which is a coiled shape attached to the colon. This is known as the apple peel sign. And then type 4, where you can see kind of many blockages in the intestine, and this is known as a string of sausage sign. So going back to the original flow chart, so we're kind of at this point in the workup, where if you find double bubble sign without any distal gas, this is pretty indicative of duodenal atresia. No further imaging really is necessary, and you should kind of consult pediatric surgery at this point. So just to talk about antral duodenal web, So these are congenital antral webs, are thin circumferential mucous membranes that are usually found 1 to 2 centimeters proximal to the pylorus, and they narrow the gastrointestinal lumen to cause obstruction. Sometimes need endoscopy to actually diagnose this. So I just wanted to talk about a little bit about different imaging modalities and their utility in aiding the diagnosis. So in the case of our patient, the abdominal x-ray was pretty nonspecific. There's no evidence of pneumoperitoneum on the single frontal supine view. So the radiologist was very clear to indicate in their impression that this was on the single frontal supine view. As I noted earlier, if obstruction or perforation or other pathology is suspected, additional projections should be obtained. And these may include a left lateral decubitus or a cross-table lateral projection. These views are ideal for neonates, as free abdominal gas can be visualized without the neonate being required to be erect. It's also ideal for children who are unable to move from the supine position due to the possibility of bowel perforation. These views allow better visualization of intraperitoneal free air, air fluid levels, and rectal gas. So for example, in this first view here, this kind of all you can see on this is that there's dilated loops of bowel. It's pretty not specific, but in the cross-table lateral view that they obtain, you can see free air in the abdomen. This is actually a case of neck, but it just shows the benefits of obtaining the two views. If you'd only obtained the first view, you may not have made this diagnosis. A left lateral decubitus is preferred over a right lateral decubitus, as it allows free gas to easily be seen as contrasted against the liver, which you can see here with the arrow mark. As well as on a left lateral decubitus, you may see air fluid levels that suggest an obstruction. This is not on a neonate, this is on an adult, but it just notes the air fluid levels here that you can see an obstruction. And if any of these findings are found, this would be indication also to call pediatric surgery. They may recommend further imaging, but it gives you a better idea of what is going on. As we discussed before, the double bubble sign is usually indicative of a duodenal atresia, but it also can be present in 17% of malrotation. So you may see this on the abdominal x-ray in cases of malrotation. Usually in the cases of malrotation, you will see some distal gas. Also, you can see on x-ray bowel malposition. So on this x-ray, you can see that the small bowel is on the right side and the large intestine is on the left. And this can be also a finding in malrotation. Although the most common finding is similar to our patient, the most common finding on abdominal x-ray is a normal gas pattern. So let's talk a little bit about ultrasound and how it can aid in the diagnosis of malrotation. So using ultrasound, you can determine the position of the superior mesenteric vessels and the relationship to the third portion of the duodenum, and that can be helpful in diagnosing malrotation. So in the picture to the left, you can see normal anatomy where the SMA, which is the A, lies to the left of the superior mesenteric vein, V for vein here. And the reversal of this relationship may suggest malrotation. So you can see that the artery is identified here by the echogenic collar, and it's to the left of the superior mesenteric vein. So this is normal anatomy. As well as you can see D3, which is the segment here of the third portion of the duodenum, in between the superior mesenteric artery and the aorta at the level of the pancreas and the right kidney. And this also notes normal anatomy. In comparison to the image on the right, where you can see that the superior mesenteric vein is located to the left of the SMA, and the third portion of the duodenum, which is noted with the arrows here, is superior to the mesenteric vessels instead of being found between the mesenteric artery and the aorta. Although this can aid in the diagnosis, a normal ultrasound does not exclude malrotation. So a normal SMA to SMV relationship can actually be seen in 29% of patients with surgically proven malrotation. And the inverted relationship can can be seen in 11% of patients without malrotation. So again, this is to aiding in the diagnosis of malrotation in comparison to malrotation with any sort of obstruction being volvulus or Ladd's bands. This does not aid in that diagnosis. So what is also very specific to see on ultrasound is volvulus. So in volvulus with malrotation, you'll see the complete inversion of the mesenteric vessels like we discussed before, but you'll also see this whirlpool appearance where the mesentery is around the SMA. This is indicative of malrotation with midgut volvulus, and this should prompt urgent surgical exploration. So you can see on this image here with the long white arrow, that's the clockwise swirl of the SMA and SMV and the bowel loops around the SMA. You can also note dilatation of the second portion of the duodenum right here, proximal to the point where it enters the volvulus. Also see on this image here where they use color Doppler, you can see the whirling vessels surrounding the small bowel loops on the transverse scan. This is known as whirlpool sign. It's very sensitive and specific. So the sensitivity of the whirlpool sign is 95.2%, and the sensitivity is 88.9%. So again, if volvulus is seen on the ultrasound, this indicates urgent surgical consult, and they should be taken to the operating room. But again, just to reiterate that all malrotation may not have volvulus, as in the case of this patient where the obstruction was caused by Ladd's bands. And so the diagnosis may not be able to be made on ultrasound, and you may still need an upper GI series to make the diagnosis. So again, going back to kind of our flow chart, if you have any of these abnormal findings on ultrasound, pyloric stenosis, and more specifically volvulus, this would indicate urgent pediatric surgery consults and OG or NG tube, antibiotics, and fluid resuscitation. If you have signs of malrotation without obstruction, it still should urge a consult to pediatric surgery, and they still will probably want to proceed with a upper GI series to make a more definitive diagnosis.
Did you take a picture of this?
Take a picture?
Take a picture of that so that I can take a picture.
Oh, so you can scan
So I
it.
can sign in the copy. Yeah.
I think
No,
so.
there's an app you can like scan from your picture.
That's incredibly helpful.
Yeah.
Oh.
I think someone's unmuted. I don't know if they had a question. Okay, maybe not. Okay, so going back to ultrasound, the actual more useful thing to use ultrasound for is to rule out intestinal malrotation. So if you're able to demonstrate the third portion of the duodenum in the retromesenteric position between the mesenteric vessels and the aorta, that pretty much is very sensitive and specific to excluding malrotation. So again, as you can see in the picture to the left, you can see the third portion of the duodenum in between the aorta and the SMV and the SMA, as well as in the picture over on the right, you can see the third portion of the duodenum in between the mesenteric vessels and the aorta. This is pretty good at ruling out malrotation, but it's not perfect. This normal anatomic relationship has been described in at least one case of surgically treated intestinal malrotation with midgut volvulus. So this recent literature has not fully been adopted. Most facilities, they may not have a radiologist or a tech to perform this specific study. And so therefore, most of the time, the ultrasound will just be utilized to rule out pyloric stenosis, and these patients will still need an upper GI series. So it's important to know the limitations of the ultrasound at your facility and what information you're actually obtaining from it. Again, though, the benefits of ultrasound is that it's radiation free. It can be done at the bedside for unstable patients. And while, while you're considering malrotation or other signs of obstruction, you're also getting information about pyloric stenosis at the same time. But again, just like all ultrasound studies, it's very operator dependent. So let's talk a little bit about upper GI series. Most of the time we won't see it or in the emergency room. but the sensitivity of upper GI series is 96% for malrotation. 25% of those cases, the findings are subtle, but 75% the findings are very obvious. So in the picture on the left, you can see a clearly misplaced duodenum with the ligament of Treitz on the right side of the abdomen, indicated by the red arrow. And in the second image, you can see the duodenal jejunal junction is to the right side of the spine, and most of the small bowel is abnormally located on the right side of the abdomen. This picture actually indicates, similar to our patient, Ladd's bands resulting in distension of the stomach with a small amount of distal gas. In this next image, you can see here, this is a lateral view, and this shows the stomach and the classic corkscrew appearance of a duodenum that's consistent with volvulus. So I just wanted to talk a little bit about contrast enema and its utility. So it was historically used, the theory being that in malrotation, the large bowel would also be malrotated, but unfortunately, in about 25% of cases with malrotation, the cecum is actually normally located. And this is because the final fixation of the colon does not occur until near term. So many newborns have a high or poorly fixed cecum, and that can kind of mimic malrotation and result in a false positive study, where also the converse is true, that the position of the cecum in normal individuals is also variable. So very rarely the cecum can be malrotated, but the small bowel is in completely normal position. So currently the practice is to actually just do the upper GI series and follow the contrast all the way to the cecum. Neither method is that helpful, either the contrast enema or following the contrast all the way to the cecum, unless the cecum is very abnormally placed. So in this image here, you can see the radiograph obtained with a barium enema shows a beak-like distribution of the mid-transverse colon, indicating obstruction, and also demonstrating the cecum in the midline upper abdomen, which is very abnormal. So this is very indicative of malrotation. Obviously, if there's still high suspicion and for some reason at your institution, you can't kind of get upper GI series, or the upper GI series is negative and there's still high suspicion, you can consider getting a CAT scan for these patients, versus possible endoscopy for antral duodenal web. So on the CAT scan, you're going to see kind of similar things that we talked about on the ultrasound. You're going to see that the third portion of the duodenum does not pass between the mesenteric artery and the aorta, and that the proximal small bowel is mostly located to the right of the midline. There's also an abnormal position of the SMV to the SMA. So again, you can see here in the arrow that the SMA is to the right of the SMV. And on the image to the right, you can see the whirlpool sign here, indicated by the yellow arrow, that indicates twisting of the blood vessels around the mesenteric pedicle, indicative of malrotation with volvulus. So in coming back to the case, the patient was taken to the operating room. A transverse incision was made in the right upper quadrant. Small bowels were visualized without evidence of ischemia. The liver and gallbladder appeared normal. Ladd's bands from the abdominal side wall to the cecum overlying the duodenum were identified and released using electrocautery. During this process, a pinpoint thermal injury was noted on the duodenum, and this was oversewn with a 3/0 silk suture. The appendix was identified and resected, and then the bowel was run. There was a caliber change from the dilated duodenum to the more distal duodenum, where the Ladd's bands had been crossing, but no additional bands were found. And then the nasogastric tube was palpated in the stomach in the appropriate position. The patient was then transferred to the PICU, intubated, and the patient then self-extubated in 4 hours. They did go on to develop cellulitis around the wound. They were treated with cefalzoline and metronidazole. They passed stool on post-op day 1 and post-op day 2. They were initially NPO with an NG tube on TPN that was draining bilious output, but then it slowed and the NG tube was taken out on day 6. They were downgraded to the floor, started on feeds, advanced their feeds. TPN was discontinued. They tolerated well with normal bowel movements, and they were discharged with follow-up. They actually came back to the emergency room 1 month after for vomiting. They were observed. No surgical pathology was determined, and they were discharged. And per the chart, they've had no further complications. So for some takeaway points, It's important to differentiate between normal spit up versus pathological causes of vomiting. Bilious emesis is almost always a sign of surgical pathology. Don't forget other causes of vomiting outside the GI tract. Unstable patients, the priority in the emergency room is resuscitation and urgent surgical consult. The importance of obtaining a 2-view abdominal x-ray in cases of obstruction and perforation. And that normal x-ray and normal ultrasound, those patients require upper GI series and admission. The most helpful imaging right now is upper GI series, although ultrasound may be gaining some favor. Trend for the future is for the upper GI series to only be used to confirm cases that cannot be definitively diagnosed on ultrasound, but using sono as the first line and going to the OR based upon a diagnosis on ultrasound is something that's really only seen at dedicated children's hospitals with huge pediatric radiology departments and dedicated pediatric sonographers. So like at places like CHOP, but it's still not mainstream for most places. Any questions or comments?